Great. So thank you, Maria, for the kind introduction and invitation to share this information with you. Like Maria said, I've been with UCLA for, gosh, like a decade and a half. And this has become one of my passions, is sharing this information of advanced care planning, what it is, how we engage in it. And it's been my experience in these presentations. People often come in with some experience or questions, or just, starting from square one, which is great as well. I'm very thankful that you've taken the time to learn more about this and see how it fits into your life. In order to get through the materials, I ask that either you ask your questions in the chat or save them to the end. I have found we get into very rich conversations and then we don't get through all the content. So just to make sure I give you all the information, we can run through it and then definitely save some time at the end for some questions, which I think are the best part of these presentations. And the acronym that Maria said, the APHSW, it's a certification in advanced palliative and hospice social work. So it's additional training and a test that one has to take. And so I went ahead and took that step to just give myself more information, more knowledge and skills so I could hold these presentations and hopefully meet all of your needs. And so I suppose I should share my screen. I almost missed that part so you could see the presentation itself. Okay. So yes, welcome. You may have received, if you had a chance to look at the email that Aisha or Maria sent out to you, there were some attachments, and if not, I will explain what they are. I really encourage you to look at the attachments either now or after the presentation. They may make more sense after. One of them is a Go Wish reflection exercise. You can actually Google Go Wish exercise and complete this online. It's an exercise, and there's many as well online that kind of get us into the frame of mind of advanced care planning. What's important to us, what defines us, what's important for us to maintain now in our current functioning, and perhaps in the future when our functioning declines a little bit or where we carry a certain medical diagnosis. So it's an actual tangible exercise to put our thoughts down, which I think is an important part of this process. And so you can look at that, and if you have questions, we can address those as well. So just some bullet points of my hope for us is that, I will give you information that will allow you to define and speak about what is advanced care planning for yourself, with your physician, with your family, with your friends, be able to discuss this and decide how it fits into your life, and be able to complete an advanced care planning document. I get a lot of questions about that. How do we start this conversation? How do I complete a form? So we'll go over that. And again, please feel free to type in the chat and can address those questions as we move through the presentation. So these are some terms you may hear. I think it's important to be on the same page as far as terms when we talk about an advanced healthcare directive and advanced care planning. Some of the terms we use in the community to identify someone that is making our decisions or speaking on our behalf is a surrogate, a decision maker, a spokesperson, or a DPOA. And the DPOA is a durable power of attorney. Legal terms are this. Surrogate. So there's a verbal appointment. So let's say, for example, I'm in the hospital and I identify verbally, I'm talking to the doctors, identify Maria as my decision maker. I say she's my person, but I don't have a legal document in place. That's a surrogate decision maker. An agent or a healthcare agent is if now I've completed an advanced healthcare directive or a living will that identifies Maria as my decision maker. It's now written and it's in a legal form. If I'm unable to make decisions for myself, but let's say Maria, we don't have an advanced healthcare directive, we don't have anything in place, she could go to court and petition to be my conservator. So be able to make decisions for me. And also there's a financial component to that as well. If none of those are in place, then generally, I mean, I could speak to here at UCLA, but also outside of this institution, generally, we look to the closest available relative. And I want to make sure we're clear on the definition of relative or family. That's really, it's been such a fluid term. It's how we define, how that patient defines family or relative. It could be a friend that they've known for 30 years. It could be, an ex-spouse that is still close with them. So we really, as we're learning about patients, it's important to know who makes up family and how they define that. So as I'm moving through this presentation, please know that when I say relative or family member, it's really how you define it. It could include a lot of different people and structures. So I've been mentioning advanced care planning. What is it? It involves learning about the types of decisions that might need to be made, considering those decisions ahead of time. That's really key. Right now, when we're cognizant, we're aware of our medical conditions, it's thinking about this ahead of time, and then letting others know about our preferences through communication, conversations. I really believe that is at the heart of advanced care planning, are these conversations that we have with our family members, with our support people, with our physicians, and often putting those into an advanced directive, something tangible that is a document that transcends medical systems, clinic visits, and is accessible to our physicians and our family members. So some of the goals of advanced care planning, I've mentioned a couple of them, is ongoing conversations about what we call goals of care. And goals of care are kind of in a nutshell are what's important for me to maintain. Is it important for me to be at home, to have meaningful engagement with others? Am I okay with being in a nursing facility? There's a range of goals that people verbalize, and all of them are okay as long as we've had conversations and we're clear on how to take care of this person and make sure we've communicated that. And this could include, discussions around resuscitation and life support, palliative care options, surrogate decision-making, and advanced directives. And I often get asked, what is palliative care? Is it hospice? So let me just sidebar for a minute in that this is how I describe it, is I imagine an umbrella where the umbrella is palliative care and a subsection of that is hospice. So we as palliative care providers come alongside the patient and family in coordination with the already existing physicians, nurses. We see people that are in active treatment, that are coming back to the hospital, that are expected to live for years. And we're called upon to be involved in a person's care to address pain and symptoms. Those symptoms could be anxiety, shortness of breath, constipation, as well as working through perhaps difficult decisions and medical updates, and helping to establish these goals of care. And so a bulk of our patients here in the hospital that we see, they often discharge back home and thrive. And so again, hospice is like, I would say, a subsection under palliative care, where someone has a life expectancy, generally it's 6 months or less, and they don't want to come back to the hospital, and their care has transitioned to be comfort focused. So other goals of advanced care planning are documentation of these difficult discussions, these potentially challenging discussions that we have for when the time comes. Our surrogate or family members are aware of our decisions. And if for some reason they're not available, then that is documented, and the providers, the physicians, can follow through with your healthcare instructions. And it's really important that the goals, wishes, values, and beliefs are reflected in your choices, are documented in this, this document, are stated in your conversations. And I just want to mention, I believe this presentation, it'll be made available to you all as well, in addition to resources. So just in case you're taking notes, you'll have access to this as well. So why do we plan? Why do we need to do this? Studies have found that when there is a medical emergency, a crisis, someone comes into the emergency room, 50% of us will not be able to make our own medical decisions. We won't be able to engage with doctors and nurses and say, this is what I want, this is what I don't want. So when that happens, by default, while a social worker like me is looking for family or looking for a directive, in parallel to that, the healthcare system, the providers will do all interventions, even if it's not desired. And so all these interventions are designed to sustain life. And some people will say, I still want all of those aggressive measures done. I want to be treated. I want to see what the outcome is, and that's fine too. Again, the key here is communication and really thinking about what our goals are. And we plan also for our family members, because it's really hard to predict patient instructions or wishes if we've never had these conversations. And so that takes some of that burden off of the family when they have some guidance on how to proceed in decision-making when there is a crisis. Otherwise, family members may be left with uncertainty and distress, guilt or depression, and often financial concerns come up of how will we cover this? How will we cover placement? And so that's part of this conversation as well. So those were some good reasons why to engage in advanced care planning, but there's a lot of reasons that people don't. And I have this slide is intended to kind of tap into that. Maybe you've said this to yourself, maybe one of your friends or family members has said this. So I'm healthy. I don't need to think about that right now. I'm fine. And this is when we do need to do this, when we are healthy, when our cognition, our mind is intact, and we can think and speak for ourselves. My family members and healthcare providers will probably do what I would want anyway. They know me. I come across many family members, and studies show that this is under crisis. Family members don't know, and it's a very stressful time, and there's a lot of what ifs. So advanced care planning can help mitigate that. It isn't really necessary until I'm seriously ill. Again, going to the previous slide, 50% of us in crisis will not be able to make decisions for ourselves. So it's important to think about this now. I don't have someone to list. And that's okay. We'll get into this a little bit later as well. You don't have to have a designated person to list. On an advanced directive, there are two things you can do. You can list your healthcare instructions and or someone to contact. And if you don't have someone, you can still complete the document. How do I know what I will want, wish, or instruct? Absolutely. An advanced healthcare directive and these conversations can't predict every situation, every medical crisis that we might be in. And so that's why, again, thinking about, the go wish exercise of what's important for me to maintain. Where do I want to be as maybe I age or my illness advances? That is something that is so important and can really guide the plan of care. I'll do it later. That's one of my favorites. I give the information here in the hospital, and many people say I'll do it later. And the issue with that is later is later, and we may need this documentation, these conversations later. I think it has to involve a lawyer, and it'll cost too much. It does not have to involve a lawyer, and it's essentially free. You have a document, and that was, I think, emailed to you, as well as if you Google California Advanced Healthcare Directives, many come up, and it costs as much as printing a document out, filling it out, and we'll go over how to fill it out. And the forms are overwhelming. They're really intimidating. I hear this quite a bit. And so hopefully today we'll take care of that last bullet point, and these forms will be less overwhelming. I can't promise they'll be less emotionally overwhelming. There are emotions involved in this, but hopefully you'll get a grasp on what they are and how to complete them. And like I said, there's a lot of advanced healthcare directives. You see 4 examples here. And the one that I believe was sent to you was the UCLA Advanced Healthcare Directive. But there's quite a few, and I always encourage people to look at them because all forms are different. Some people like very legal looking forms. Some people like something that is, and there's a picture there, prepare for your care, and I'll include that in the resources. I'll be emailing Maria to forward to you. And that one looks a bit less legal. It almost looks like a workbook, and it's very user-friendly. The language is, I think, at a 6th grade level, and that's what studies recommend for documents like this. It should be at a 6th grade level because there is an emotional component. Excuse me, I'm just going to take a little sip of water. There is an emotional component, and so having that in an acceptable or accessible, I should say, reading level makes it a higher chance of completion. So let's get into what the Advanced Healthcare Directive is. Do any of you, do you all have it there or accessible? Okay, in case you don't, actually what will be coming up are screenshots of the document. And we can go through it. And so this is, again, one specific Advanced Healthcare Directive. It's the UCLA Advanced Healthcare Directive. You can complete any version that you like. It doesn't have to be UCLA. It does need to be a California Advanced Healthcare Directive. Each state has their own guidelines, their own regulations on an Advanced Healthcare Directive. I will tell you that, you know, being at UCLA, we do see patients from all over the country, all over the world. And there's been a handful of times when patients come here for treatment and they come from out of state and they bring that directive, and they may not have had time to complete a California one. We will still go ahead and honor that, assuming it's completed, witnessed or notarized, because the instructions are still there. So I bring this up in case some of you travel out of state. I know some people live out of state for certain, parts of the year. It may be beneficial to look into what directive is in that state, or make sure that if you're going to interface with any providers at the other end of your travels, to make sure they at least have a copy of your documents here in California, because those are really strong guides that we turn to. So let's go a little bit over the form. And so it's a bit of introduction to advanced care planning, which we went over. I think what's unique about the UCLA directive is that it really starts with your values and goals. And that really highlights, I think, where medicine is trying to go, where they are, and I say they kind of as a system, providers, nurses, social workers, chaplains, really trying to get to know patients and what makes you you, and what's important for you to maintain. And that informs the plan of care and what recommendations are made, in addition to, the clinical picture and medical information. I think it's often been very, we can do all of this to you, but is that going to maintain your what we call quality of life? So on this page, it really asks the person that's completing this document to think about, how they want to be treated, what's important to them. For those of you that may not be able to see the screen, I'll just read the first part. For example, I would not want medical treatments to try to keep me alive if I could no longer. And some of the options are, and you can check off as many or as few as you'd like. Some of the options are: live without being permanently hooked up to a breathing machine, recognize family and friends, talk to family and friends, feed, bathe, or take care of myself, live without severe pain or discomfort, and think well enough to make everyday decisions. And there's a part there, a narrative part, where you could add some handwritten, a paragraph. And with the Advanced Healthcare Directive, you can also add sheets of paper. Oftentimes people have very detailed instructions of how they want to be cared for, what's important to them. I've seen some people write in, it's important to have a certain type of music or a certain type of atmosphere. People are very much into aromatherapy. No detail is too small. And so these first few pages really move us through our goals and values and who are we. And on the following pages, it asks about life support treatments like CPR. Is that acceptable? What is important for us to know? And any other beliefs or values that you would want your healthcare agent, meaning the person you've designated to speak on your behalf, to know if you're unable to speak for yourself. And is there anything else you want your healthcare team to know about your religion or spirituality? I think this is for some people, it's a large part of our lives, our religion, our spirituality, our culture. Culture defined as, what is our family norms? What has been your lifestyle? All of those things can go in there. And this is really designed to be a document that reflects you. And so putting all that information is really helpful. And on this page, it asks a little bit more about religious and spiritual leader and community support. Is there anyone that we should reach out to? And if you're so ill, if we're so ill that I can't recover in my usual residence, where would I want to die? Where would I want to be? That's a really big and hard question for people. And so some of the options here: at home under the care of hospice, in the hospital, in a skilled nursing facility, and maybe I'm not sure. My healthcare agent can decide this, or maybe it's not important to me. Those are some options as well. And that's okay. Some of these things may be undecided, or you're unsure about them, and that's okay to write on the document as well. Again, the heart of this is the conversations you have with your healthcare agent, with the person that will be following through with these instructions. Again, these documents are designed to for us to think about these things and document as much as we can. Some of things may be uncertain. So the person that you do pick, or people, ideally should know you and know what's important to you. If some of these things are still undecided at the time that you complete the document. So choosing a healthcare agent, who is this healthcare agent? What do they do? What are their responsibilities? In this directive, it itemizes, it lists what the healthcare agent is able to do. I like to describe it in a nutshell as an extension of your voice. So ideally, it's someone that you trust, someone that you've talked to about your medical condition, your lifestyle, and the decisions and the instructions that you've put in this document. There's been a few situations where I have a beautifully completed advanced healthcare directive, and I call the person that's listed and they have no idea they're listed as a healthcare agent. And that's very concerning, because if that person doesn't know that they're listed, they probably don't know what the healthcare instructions are for this patient that I'm taking care of. And that's been a safe assumption. It's been proven to me. They have no idea. I'm not sure what decisions to make. How can I make decisions? I haven't talked to this person in X amount of time. So it's really important that you talk to this person about taking this role. And I get this question sometimes in presentations of, I have 4 children. How do I pick one? There's going to be disagreement, or they'll wonder why I picked one over the other. It's really important, or they want to give joint responsibility to all, and that can be a bit troublesome. So it's really important to pick one person, but this is really important too. That one person is, let's say, the voice of the family as well. The other people will still be involved in discussions and decision making, but there really needs to be one point person. It just helps streamline communication and make sure your healthcare instructions are conveyed. And it could be, you know, for some people that are married or that have siblings. It doesn't necessarily have to be your spouse or your partner. It doesn't have to be a family member, even if you have family involved. Again, it's someone who can follow through with these responsibilities and be an extension of your voice. And there is a place on this document where you can list 2 people, the healthcare agents. One is a primary, and then there's a secondary. So for some reason, the first person is not available, we go to the second person. You can also add sheets to this. You can add some other documents allow a third or a fourth person to be listed as alternates. You can add a sheet to this. And you'll see on the bottom of this page is, have you discussed your healthcare preferences with your healthcare agent? Again, that's a really important question, and it's kind of unique to this document. And it prompts you, if you haven't talked to them, then to talk to them that you're completing this and what is involved in this document. And like other directives, this covers our organ and tissue donation and body donation. I often get questions about the body donation portion, and there's a resource here, the UCLA donated body program, and there's others. If that's something that you are interested in as you're completing your advanced healthcare directive, it's a good time to look into these programs because they do require an application ahead of time. And that can be burdensome to some family members as where they're making decisions, you know, under crisis or making decisions for their loved one to also navigate this. So that if that is something that you feel passionate about, and coupling it with your directive is a really nice way to do it. And so I've completed my document. I feel it's really thought through. Maria I'm going to use you, Maria, as my example. Maria has agreed to be my healthcare agent. What do I do with it now? So in order for it to be legal, it either needs to be witnessed or notarized, one or the other. You don't need both. And so on the screen right now is where you sign. And so you're going to hold off on signing this part until your witnesses are present or the notary is present. Some people do both, but you don't need both. If you are in I don't think any of you are, but if you or someone that you might be sharing this information with is in a nursing facility, they require an ombudsman to be present to complete this document. And the facility can help coordinate that. Sorry, Maria, I was just looking at your chat. For those that maybe didn't see it, please feel free to type in your questions as you're thinking of them in the chat, and I'd be glad to address them. And this is the following sheets are where the witnesses sign and the notary. This is really important. I have seen some completed directives or partially completed, except this part, and people do think, well, I've completed it. It's legal. It's not. And for some reason, I've seen some people too, they complete it, but they just didn't have time to witness it, and families will bring it in. We will still use it as a guide, but know that it's technically not a legal form. So that's all of that was about advanced healthcare directives. Now I want to talk to you about something called the POST. The POST is, the acronym stands for Physician's Order for Life-Sustaining Treatment. It's a hot pink form. And again, it was probably in your, I don't think you did, yeah, in your email that you received or will receive. And so I like to mention this for education purposes. So you're aware of this form, and if need be, you can discuss it with your physician or someone in your life that might benefit from it. The indicators for completion of a POST are if you're seriously ill, medically frail, and have a chronic progressive condition. One of the guiding questions has been if the doctor feels I may die within the next year, that my condition is so frail that we're having conversations about that, then that would point me in the direction of discussing the post and completing it. Again, this form is really, these forms are great springboards for difficult conversations. If my physician said you have, a life expectancy of a year or less, I would want to have conversations about the content of this form so that I know how I'm going to be taken care of, and I can express to others how I want my body, my spirit, myself to be taken care of, and where and how. So how do we complete this? This form has to be completed with a physician, a nurse practitioner, or a physician's assistant. So when you go see your physician, let's say you talk to the nurse practitioner or there's a physician's assistant, any of those disciplines can complete it with you. I can, as a social worker, I've been trained to give education, but I'm not a physician, a nurse practitioner, or a physician's assistant. So I can't actually complete it and sign off on this form. And that is intentional. This is so that these medical providers are prompted, forced. They have to have these conversations with you. And this gets much more specific than the Advanced Healthcare Directive in the instructions that make up delivering medical care and the focus of the medical care for you. This is legally binding across healthcare sites in California. So this form is specific to California. Other states do have a similar document and may be called, instead of a P and M, so a MOLST. So again, if you have family members, friends outside of the state, or you travel a lot, it might be helpful to look into this if this form does apply to you, or you have providers that you see outside of the state. And it's valid, just like the directive, it's valid only if appropriately and completely signed, meaning that your signature or your representative has to sign it, and so does your medical provider. And I think we kind of already went over the differences between the directive and the post. So we'll move on. So let's say I have completed my advanced directive. I have my post. It's great. It's sitting on my nightstand or in my safe at home. What do I do with it? You want to make sure to distribute the post actually to the advanced care planning documents, to any pertinent family members, friends, physicians, providers, clinics that you go to. At UCLA, we have, if you go into a clinic visit and they upload it into your chart, it's accessible to the whole system. I was waiting to hear from my chart to see if patients can now upload these documents themselves, but I didn't hear word before this presentation, but I know that's something that they've been working on patients being able to upload their own documents, which I think would be really, really neat to have. So in case they're completed, between clinic visits or hospitalizations. And as stated earlier in the presentation, advanced care planning is an ongoing fluid process. Things change. Our medical condition, our bodies, where we live, a lot of things change from year to year. I mean, the past 2 years have been very dynamic in the changes we've experienced, and all the things that are going on in our world. So we want to make sure that any changes are reflected as well. So some indicators to review these documents and conversations are if we have a new medical condition or scheduled surgery, change in family or agent circumstances. So the person we've designated as our spokesperson, our healthcare agent, have their circumstances changed? Do those people need to be revised or, numbers updated? Have I moved? Have I moved out of state? Do I need to look at my documents again? Do I have a new physician, a new provider? This is a good opportunity to let your new provider, I've completed these documents. I want to review these with you. And I want to make sure we're on the same page as far as how I want my care to go or what's important to me. And that's something that I get asked to in presentations of, my physician doesn't really talk to me about this, isn't initiated. And some, there's a lot of different approaches to this in the community. So it might be up to us as patients to initiate these conversations with our medical providers. And at a minimum, every 5 years. If none of these apply, nothing's changed. We want to make sure you review every 5 years. And as I had mentioned earlier, I was at a training for advanced care planning last night, and they mentioned the 5 Ds. So I included this. If any of these things, again, it speaks to the changes that are listed above: death, divorce, disability, diagnosis, and make sure you check the documents for accuracy and make sure they're current every decade. I recommend 5 years, but again, if there aren't any significant changes, every decade is fine. We talked a bit about already document distribution, making sure these documents are not a secret, that the people that need to know about them, have the information, and also make sure that people have them that may come to the hospital to visit you in case they need to be brought in. I just want to give you some statistics as I get close to the end of this presentation and open it up to questions. There was a few studies that showed that about 23% of Californians have written advance directives. I think that's a very low number, especially in contrast to what this study also found, that 70% or more of Californians would prefer to die at home. But 60% of us at the time of that study currently die in facilities. That's a big discrepancy where people, I think it reflects people maybe aren't thinking about advanced care planning or not communicating their instructions to providers and family members. And so the consequences were having care delivered and potentially dying in places we don't want to. We're in a facility. And so I'm hoping through presentations like this that 23%, that number goes up and the other numbers go down. And we're really taken care of, and we're in places, and not just a physical place, figuratively as well, and other levels where we want to be when our illness progresses, or when it's the end of our life, that we're really, the things that are important to us are honored. So I'd like to open it up to questions. Hopefully you have questions. I feel like I've given you a lot of information to digest. And part of that, there's this resource page that you'll be getting as well on where to contact me and other resources here at UCLA that will be shared. Should I stop sharing my screen? Okay, so we can see each other.
Before we go into the questions, Delia, if you don't mind, if I could just interject for just a second. I wanted to first say thank you so much. And you're right, it is a lot of information.
It is.
You do a great job of presenting it. So thank you so much for that. I'm thinking that there will be some questions, and we'll go ahead and take those questions. I wanted to say that I was remiss. I neglected to introduce Lam Liu, who is our new staff member in the ERRC. And Lam, thank you so much for putting the information in the chat that you did. And I just wanted everyone on here to know Lam. Lam, if you can kind of maybe just wave.
Hi, thank you for introducing me.
Yeah, thank you for being here. And thank you so much, Delia, for your presentation and for letting me interject that information. And we'll go ahead with questions. Let's see.
If no one has questions, I have a question for for the participants, I'm curious to know what brought you to this presentation. What brought you here, and what were you hoping to learn or still maybe have questions about?
Feel free to unmute yourself.
Mm-hmm.
So let's see. Maybe it's not something that people feel comfortable sharing.
I think Melissa has something to say.
Oh, good. Go ahead, Melissa.
Can you hear me?
Yes.
Oh, wonderful. Yes. Well, for a number of years, my very astute primary care physician has said to me, you need to take care of this. Please pick up your
Oh, you have it there.
So I've had it, and of course I haven't done anything about it. And then what happened is right when COVID hit, I began a journey of very catastrophic health crises. First, I was diagnosed with stage 4 cancer of a very rare cancer called Merkel cell carcinoma. And at the same time, I became critically ill with COVID and had severe respiratory failure and pneumonia, and was hospitalized in the ICU for 5 days, a month before my scheduled surgery for the cancer. And then when that happened, my endocrinologist diagnosed me with Cushing's disease, and I needed to have my adrenal gland removed. And and so all of this happened. I went through numerous surgeries and recovery from COVID and radiation therapy after the surgery for the cancer. By the way, I'm cancer free. And then I was diagnosed because of the PET scan for the after radiation for the cancer. They detected some suspicious nodules on my thyroid. Was biopsied, had the nodules were cancerous, so I just had a thyroidectomy in March. So all of this has happened, and so I've been looking at my pamphlet and saying, this was on my mind the whole time I was going through all of this. I was thinking, gee, anything could happen, and it's a slippery slope, and I didn't take care of this, and that's not good. So now I'm on board. And I just want to say I'm so incredibly lucky because I have the medical care from UCLA, which is the most amazing healthcare you can get on the planet. I'm here to say the best doctors, everything. They saved my life, and I'm doing really well. But thanks to the medical care I got at UCLA. But I have to say, I really wish I had taken care of this, because if my outcome had been different, I would have left a lot of loved ones in, a much tougher situation. So I urge everybody to really, you don't know when something's going to happen. You never know what diagnosis you might get, or when you could get critically ill. So I'm just here to say this is really important.
Thank you, Melissa, for sharing your story. It highlights so much of what I hope to convey in such a much better way through sharing your story. And oftentimes, people move through a crisis, and I'm so glad that you're here with us to share this knowledge, this wisdom. And that's what prompts us to actually look at the document, pick it up, and because maybe we've tinkered with it a little bit in the past, we know about it, but this, it sounds like it's really motivated you, and that happens with a lot of people too. I've been through this, I've survived this, and now let me leave this gift it's really a gift to yourself and your family.
How do I receive a copy? How do I receive a copy?
Yes, we will be sending out resources in a follow-up email, Barbara. So you will get it. Yeah. Thank you. Good to see you, Barbara. And you too, Melissa.
Thank you, ladies. This was really wonderful, and I'm very appreciative that you offered this. Thank you.
Yeah, and as you're moving through it, not just you, Melissa, but maybe hopefully the rest of you looking at it and using it. I always give, when I see patients, I give two. I really recommend using one kind of as a worksheet, kind of thinking it through, or perhaps that's my projection. I'm that kind of learner that I process that way. What do I want people to know in an unedited way, right? Just put it out and let me see it. There's something very therapeutic about taking those thoughts, those feelings outside of our body and putting it on a piece of paper. And then there's the other, the second one I give out that will become the actual document, the legal document. And as we're talking to family members that, might be involved, there are notes too that go on that worksheet. And that document starts taking shape. Like I said in my presentation, it could be, and for many people it is, a series of conversations with ourselves, with the people around us. Like you're sharing, Melissa, you had a very profound, meaningful experiences, and that will be, that will come through in your document. It should be something dynamic. Yeah.
Yeah.
Any other sharings or questions? I think you covered everything so well, Delia.
Oh, thank you.
Yeah. So,
thank you.
Yeah.
Yeah,
Is there anything you wanted to add? I
would say, take this knowledge. It's a lot of information, I know, and you'll have, I'm always open to questions after some of these presentations. People do ask me questions, and please feel free to reach out. Look at the document, just take a look at it and see what comes up to you and what it feels like. And then, the next step is moving through it, kind of like how we were discussing in this presentation and with Melissa. And if this document for some reason doesn't speak to you, like I said, I'll send you some links to some other documents. There's Prepare for Your Care and 5 Wishes. They're described to me by some people a little less legal and more accessible. This is like I've said, this is a personal dynamic document, so it should really reflect who you are.
Where can I get all this form I needed, like post POLST or other
yes,
other one? Where can I get this one?
Yes, you'll be getting an email with all these resources.
That's correct.
And they'll have the document attached in addition to the links, so you can actually because all of these documents have a link attached to them, which gives even more information. And you can actually complete some of these online. And for those of you that maybe have I know we're doing a lot of virtual visits, like doctor's visits, clinic visits. Are some of you engaged in those? It's really neat in our system. I feel so excited about this. We can actually do the post, if it's appropriate for you, online in the chart. It's an e-post. And so some of these can be done electronically as well. And we've done the post with people that, like, the family members are out of state. So this, although there's been so much that we've had to deal with the pandemic, I feel like this is one silver lining where we've really moved to do these virtually to make sure people have access to the information and they can be completed even if, from your homes.
So you mean I can get this form from email?
Mm-hmm.
But, okay, thank you.
Definitely. And you asked Maria what my other piece of advice would be: talk to your providers about this. I work with a lot of physicians, and there's a range of, just like us, right? We might not be comfortable during this presentation, not sure what to expect when we walk in. And hopefully you feel a little bit more comfortable with knowledge. Hopefully you feel more, you can grasp it a little bit better. But same thing with physicians. Not all of them have been trained on this. Not all of them have been trained on how to initiate this conversation. I hear a lot from physicians, well, they're not ready to have this discussion, or he's not ready. And I think it's more kind of wanting to protect their patients, their heart. And so it might be on us to bring this up, and normalize that this is something you want to talk about. Like, I went to this presentation and I want to talk to you about this. And so I feel like that might be something, that might be a tip too, to open up that conversation with your physician.
Thank you.
That's a great point. Yeah, thank you for that. You're right. I mean, it is, touchy subject.
Sure.
So yeah.
And like this, if I'm healthy, if I'm relatively healthy and I'm okay, why do we need to talk about it? But like you're saying, Melissa, you never know what's around the corner, and it's advanced care planning. So, yeah.
Perfect. Thank you so much, Delia.
Thank you.
Really, we really
Thank
got a
you,
lot of
Delia.
helpful information today. People are making notes in the chat telling you
Great.
that it was very helpful. So thank you again. And I hope that we will be able to do this on an annual basis. I really just think that it's something that we need to pursue. So
I hope so too. It's great to be invited. Thank you for giving me the space to share this. And if you hear where other topics that I could help with, please feel free to reach out. And I look
Definitely.
forward to seeing you all soon.
Thank you all for coming.
Thank
Good to
you,
see
Maria.
everyone. Yeah, thank you, Barbara.
Thank you.
Okay, take care. Bye-bye. Have a good rest of your day.
Bye-bye.
Bye.
Thank you.